Greeting from the American College of Surgeons. My name is Girma Tefera. I'm the Medical Director for Operation Giving Back. I'm here together with George Tsoulfas, who is the chair of the International Relations Committee, to welcome you to this global webinar today. It is going to be focusing on surgical leadership in time of crisis, as we communicated to you through our brochures. We hope this webinar will provide us an opportunity to get together, listen to each other, and learn also from our current challenges as it pertains to the pandemic that we are in, and so many other crises actually that are happening around us every day. Moreover, I also hope that this is going to be the beginning of a new tradition so that the global surgical community can come together occasionally like this online, and we can actually support each other better. So first, a couple of housekeeping issues like anything else. I mean, of course, it's not going to involve where the bathroom is kind of thing, but there are always on Zoom some housekeeping issues as well. First of all, I would like for all the attendees to keep their mics muted so that we don't have unnecessary interferences. We will have all the panelists and the speakers will have their videos on, and they will have also their mics muted when they are not speaking. During the webinar, we have a Q&A function. Everybody can send out questions or comments that both myself and Dr. Tsoulfas will look at them and ask the questions at the end during the Q&A session to the panelists. During the presentations, myself and Dr. Tsoulfas' video will be off, but if you see us come up, it means the speaker has about a minute to finish the presentation. So that will be a soft indication for you that time is really running out. So with that, we have really distinguished panelists from across the continent, except for Australasia and Antarctica, we have everybody. And that was also pretty much because of the time difference, really, that we did not include someone from Australasia. Without any further delay, I just want to first invite Dr. Valerie Rouge to give us opening remarks. For those of you who don't know Dr. Rouge, she is a Vice Chair for Clinical Research in the Department of Surgery at Memorial Sloan Kettering Cancer Center. She is the current president of the American College of Surgeons. And Dr. Rouge, thank you for joining us. And I would like to give you this virtual floor to give an opening remark. Thank you.
Well, thank you very much, Girma. It's really a great pleasure to participate in this webinar, which, as Dr. Tefera just mentioned, we hope will be one of many coming up in the future. I suspect that there's no one around the world, no country, and no group of physicians and surgeons who've been untouched by the COVID-19 pandemic crisis. And it's certainly been a learning on the job experience for all of us, really a supreme challenge in terms of how we maintain optimal care for our surgical patients and also adjust in many instances to providing critical care for COVID patients. The ACS has responded to this challenge in many ways, and I think you'll hear a little bit more from Dr. Hoyt in that regard. You'll find on the ACS website, if you're interested, a series of electronic newsletters that we send out twice a week to all of the fellows of the college, really to provide a single source of medical facts as they were evolving through the crisis. And we've also recently summarized our experience in an article that is currently in press in the Journal of the American College of Surgeons that will describe how the college responded to the events of the last few months. But more importantly, I think that this webinar is an opportunity for us to learn from each other. to learn how other countries have managed this challenge and how each of us can take home lessons for future management or future approaches to crises of this type. And perhaps also learn how we can collaborate around the world to be supportive of one another and supportive of the surgical community. So I will just stop there. We don't want to spend too much time simply focusing on the ACS, but I did want to welcome all of you and really invite you to have a strong dialogue when we move into the question and answer period. And I think the next speaker is Dr. Hoyt. Is that correct, Girma?
Yes, yes. Thank you. Thank you for being on time and the message. And the next speaker is Dr. David Hoyt, and he doesn't need really any introductions. He's very renowned trauma surgeon for many, many years, and he's currently the executive director of the American College of Surgeons. And he will tee us off with a presentation on crisis leadership. So Dr. Hoyt, floor is yours. Thank you.
Well, thank you, Girma, and thanks for putting this together, and Val for your comments, and Dr. Turner for all you do with helping support the OGB program. My charge is to talk a little bit about leadership at a time of a crisis, and I think we've all learned a lot from it. I think I'll start out by saying that I don't think there are more natural born people to be leaders at a time of a crisis than surgeons. That's what we essentially do every day in the operating room, or potentially run into that. And so that really gives us a framework for some principles that I'm going to go through briefly. And I'll try and link them to a little bit of what we actually did the last several months in that regard. A lot of this came out of a series of discussions that I've had over the last couple of years with Dr. Pellegrini as well, who's been involved in a lot of leadership training for our college. And so actually some of these things will be written up in a bulletin article forthcoming this month. But we titled this Crisis Leadership because it's not just how you react day to day as a leader, but what do you actually do in a time of crisis? So there's several principles, and I'll just kind of, again, link them to the situation we've just come out of. But the first is, as a leader, you've got to be present. I made a decision 3 months ago to basically stay in Chicago, go to the building, be a central resource for people, help to coordinate as people figure out, how to respond to things. And that was absolutely the right decision. It allowed me to work with all the staff, but then also work with all the fellows and volunteers to get them what they needed and help coordinate things, which is really my job. We did this by creating a set of resources, and that initially for the internal part of the college was to create an IT infrastructure. So within about a week, we had virtually moved the entire 450 people back to their homes with appropriate infrastructure, and that worked quite well. Again, by moving into the college, I was able to then have 724, 365 resources. And if you think about any other crisis, being present as a leader is probably one of the most important things you can do. Second principle is to communicate, and that means to communicate totally. By that I mean to cover every subject that comes up, do it frequently, and that you have to figure out the pace at which you do that, and most of all, be truthful about it. People, when they're in a crisis, they're anxious. They mostly just want to know the answer. They can accept difficult answers. But if people are left to their own to second guess, that's when the problems start. So one of the things we did early on in the college, and it was really an idea that came out of Dr. Rush's thoughts, was to, rather than have our multiple communication channels, we took all those resources and combined them to communicate with fellows, but also with the staff on a regular basis. Initially once a week, we went to twice a week. But the intent was to have one source of truth during that period of time. It's also important early on to emphasize what's important. And as you think about this in the last couple of months, as we've all gone through this, we've had a lot of debates. Do we need to stop surgery? Do we need to do this? Do we need to do that? You've got to have a set of principles that guide you when there's a conflict. And what we chose is to emphasize safety, both to staff, to surgeons, and to patients, to provide care as best we could while going on. Financial solvency was important, but it was really secondary to these other two. And then perhaps, again, most of all, perhaps to provide hope. That's done through defining the current reality, trying to predict what's ahead, and put a positive spin on it. Now, another way to put that is to exercise as a leader pragmatic optimism. And I think you all know who Lucille Ball is, and she was a comedian, but I think she has a very nice quote here. Making optimism is a way of life that can restore your faith in yourself. And I think that's very true. If you think about it, if you can talk yourself into looking at the positive side of things, then that as a leader reflects on you, but also the situation, and others then connect to that. So it's really important, no matter how difficult things are, to, as a leader, maintain that pragmatic optimism. You've got to be inclusive. You have to listen. You have to be sure that the people that may be affected, that you haven't thought of, are included so that you can gauge your response to include them. And you've got to be approachable. And so again, this is where managing your own emotional intelligence is very, very important, because the stress gets to leaders just like it does to anybody else. And you really just have to always have that extra moment to listen to somebody, let them tell you their side of the story. And you get so many conversations where everybody has to say the same thing, but in their words. That's an important exercise to let people participate at some level. You have to manage it, but even amongst our fellows and our volunteer leaders, it's very important that we let everybody have their say-so. I think maintaining a sense of humor is important. We've all seen some of the stuff that's gone around, and it's really important to not only allow that, but encourage that so that people maintain their balance. And for us as an organization, we really emphasize our values. We set these together about 7 years ago. They've been very helpful. So professionalism, excellence, inclusion, introspection, innovation, those are all important values when you're in the middle of a crisis. Now, you have a lot of constituents as a leader, and you have to manage those relationships. And for the college, for instance, this would be slightly different in a hospital, but it's a similar principle. You've got to manage those relationships. You've got to think about them. So for us, it included the fellows and the staff, our governing structure, our board, our presidential line, our board of regents, our governors, et cetera. We had to think about financial accountability, and that's a very stressful and difficult thing. But actually, by having predictive models and applying those, you can get a sense as to what your situation is, what it might turn into, and then monitor that. And with that, create a lot of assurance to people that you're okay. Or if you're not, that what the timeline is for thinking about things like cuts or furloughs or salary reductions, or all the various things that people have been involved in. For us, we also needed to be responsive to the government. The government was very extensively trying to help at the federal level, but also at local levels, the management of hospital resources, the management of decision-making about whether to curtail surgery, et cetera. So we created a communication channel with them, and Dr. Apelko was the lead on that for us. But basically, we had daily conversations with CMS and with the government and with the White House staff about how to make decisions regarding surgery. And then finally, we also were engaged with the military, because they were a resource that at least at one point they built 17 overcapacity hospitals, and we were involved in helping them think through and plan that. Now, a basic principle that I think is relevant to think about particularly in a crisis, is the concept of a VUCA moment. When the situation that you're dealing with is variable, it's uncertain, it's complicated or complex, and it's basically constantly changing and unpredictable. And people that write about this or think about this from a leadership standpoint describe this as really the strategy that one uses during war, so-called, how do you create a strategy through the fog of war? And it's a leader's responsibility to really try and come up with something that's a vision for how to get through it. It might be wrong. You may have to change it. It may even be fleeting. And during this crisis, you saw us all having to change our direction every couple of days sometimes early on based on a different situation or a different set of conditions. But as a leader, you really have to be on top of that. You have to be spending time to examine what's going on and try and at least point the direction through that fog of war. And so that's what I mean by being strategic. The easiest way, I think, to define a strategy is if you've got a wall to climb over, where do you put the ladder? Again, you may move the ladder. The ladder may not be in the right place, but you've got to have a plan to start. And if you think about the last 3 months we've all been in as leaders, we've constantly been asked, what's the strategy? We don't necessarily know better than anybody else, but our responsibility as a leader is to point the direction. And the best way to do that is to think about it and have something clear in your mind that provides leadership. So for us, what this meant was initially to recommend physical distancing, like everybody did. That ultimately came to a decision to curtail elective surgery, which was very controversial at the beginning. We then created a structured process with guidelines and committees to work through that by disease site, and all of that's available on the web. But that was in response to coming up with a strategy to try and help bring what we could as surgeons to this crisis, which was to bring capacity, safety, and to protect the need for responding to the infectious disease crisis. We did that by creating an organizational structure called Incident Command. This came out of the U.S. Fire Service about 40 years ago. It's what's been used for disaster management, and it works very well. So inside the college, we created an Incident Command Committee. It met essentially early on every day and then tailored back. But it became the way in which resources, communication, needs were communicated. And once a day, we reset what our strategy was. And then as Val alluded to, we created a communication plan, which we decided to take all the resources that we had, including the web and our traditional newsletters, and combine them into something that was focused on this crisis. And it allowed the resources to be available to do that. And I think it came off very well. So those are just some basic blocking and tackling strategies that are really important no matter what the crisis is. You have to think about the scale of the crisis and how that affects you as an organization or as a leader. And so again, when we were at a low incidence situation, it was simply a matter of dealing with things like physical distancing. But the decision to slow down or even stop surgery, particularly when the government was trying to deal with that, we had a responsibility within our surgical community to help think that through. And it was really in the interest of protecting ICU beds, protecting equipment, which you remember at the beginning of this was very limited, specific things like ventilators, and then to protect the staff as well. So our involvement included the Army Corps of Engineers, FEMA, private groups that were creating things like airplanes that could be landed in airports to provide ICU beds, and then the local conversion of facilities. And you can see there the build out that occurred at the Chicago Convention Center. It was never used actually, but those kinds of things, people are reaching out and asking for help. Now, there's a lot of detail and we're not going to go into it, but it's important, that you help set some principles, and the quality programs that we've had in the college have been very helpful in trying to suggest to a hospital how to go about doing that. So just like you have a multidisciplinary quality program for a cancer program or a trauma program, we suggested to people to create an internal governance committee structure that included nursing, administration, physicians, surgeons, et cetera, to try and deal with in their own hospital a structural way to deal with ramping down and then ramping up surgery. It had implications for thinking about diagnostic testing, and you all know how complicated that was and has continued to be. Initially, it was overwhelmed by this need for personal protective equipment, what was right, what was wrong, what was important in the operating room, what was important in the hospital, et cetera. And then what and how should you deploy hospital staff? And many, many surgeons, about 40% of a surgical workforce, at least in the United States, participated in non-surgical care during this epidemic. It's useful to have tools, and this is a tool that you've probably seen that came out of the University of Chicago, which is, I'm not really endorsing this so much as it's a thoughtful way to think about how you triage. The college put one of these out very early. This one was developed at the University of Chicago, but it applies a score to allow you to triage your patients. And these kinds of things, again, a leader has to convene the group that then puts the work in to come up with something like this so that it starts to give people a way to stay organized and not get overly stressed. Now, the recent focus for us in the college has been to continue to bring the lessons that we've learned early on from certain sites. So for instance, Dr. Roosh, our president, was in New York. New York was really a bellwether of what we all thought was going to happen across the country. So we used that as a way to learn. We planned, in some cases, we may have over-planned based on the principles that they were experiencing in New York, but it was a very useful kind of thing, and it really helped assure people how to anticipate what was likely to happen in their community. And now we see, that maybe even some of that over planning is going to follow in terms of what's happening in some of these communities. But when you have a national organization, you can use it to get lessons learned in one area and communicate them with another. We have a pretty good disaster infrastructure in this country, but it's designed to respond to one geographic area. So COVID, what it did is it overwhelmed multiple places at one time, and nobody's had a real experience with that historically. We are going to study that and have put together a grant that hopefully will be funded to study sort of as an action after report. But again, while you're in it, your responsibility is to constantly monitor and learn and then share. And the communication channel became very important as a way to do that. And we were able to follow the hits on the website and that kind of thing to know whether we were making an impact, and it seemed as if we were. So I'll just end with, in addition to all those kinds of things we just talked about, it's really important as a leader to take care of yourself. People are relying on you. If you don't sort of have that predictable, upbeat, and sense of humor attitude, if you're not available, if you are personally, emotionally distraught just because of whatever's going on, you really you don't have to take yourself out of the game, but you have to take care of yourself. Get sleep, eat, and if you watch Dr. Fauci over the last 3 months, his wife would actually make him eat so that he stayed nourished. I think it's important to try and exercise and again, preserve your own emotional intelligence, because in a long-term effort like this, that's the thing that's going to get you through is to really believe that you're going to get through it and project that to everybody else, and then always keep looking ahead. So Girma, I'll turn it back to you.
Thank you, Dr. Hoyt. And I realize we have really asked an attainable task to, be communicated in a very short period of time, but, you all get the message. We'll have also in the Q&A session, we can ask questions and maybe amplify some of the messages. So I will ask Dr. Tsoulfas to introduce the next speaker.
Thank you, Chairman. Our next speaker is Dr. Patricia Turner. Dr. Turner is an accomplished general surgeon who serves as Director of Member Services of the American College of Surgeons. overseeing all membership-related initiatives and activities across the organization. Patricia, thank you.
Thank you so much for the kind invitation. And thank you to you and to Dr. Girma for hosting, to Dr. Roosh, and to all of the fellow panelists, Dr. Hoyt and others who I honestly look forward to hearing from others, because I'm sure there are leadership skills that I too can learn. And I look to learn more than I can contribute. I think Dr. Hoyt has done a great job of outlining specifically as it relates to COVID what has been done at the college, and there may be some meaningful elements of that we might discuss later. I thought I'd take a slightly different tack. I don't have slides. I just wanted to cover just a couple of tenets of leadership that I think are universal. Not only specifically related to COVID, but in terms of leading in times of crisis. Dr. Hoyt touched on the first one that I think any of us would use as a launch pad, which is that notion of communication. Effective communication with one's team, with one's constituents, is a critical element of leading in times of crisis. By its very nature, crises are unpredictable. By its very nature, crises are ever changing. And in order to A, engender confidence in your leadership, and B, make sure that you're making the best decision possible with the information available to you at the time, ongoing communication in both directions, communication from you as a leader out to your constituents or teams or members, and communication back so that you can know what is happening with those who have their boots on the ground, so to speak, is a principle that I think is so important for us to remember. A second principle that I'd highlight is this notion of being empathetic. In times of crisis, again, I think it's important for us to realize that everyone is not coming to that crisis or being impacted by that crisis in the same way. And it requires us to have a certain element of empathy as leaders, because we have to try to understand what all of our stakeholders are experiencing in order to cobble together a solution to that complex problem. So for example, as an academic surgeon, I may have different needs than those who are rural surgeons expecting to make it through the COVID crisis, to use that example, in a rural or austere environment. I may be a physician and I have individuals on my team who are not physicians, who have additional resource concerns when compared to what I may be experiencing. There may be individuals on our healthcare provision team who have issues unrelated to their jobs that yet impact their ability to do what they do. So whether that's a childcare concern or an ill family member or other responsibilities that they have, we have to be mindful and empathetic for all of the things that impact the members of our team as we try to cobble together an appropriate response in times of crisis. A third tenet I'd highlight would be that of innovation. As the saying goes, never let a good crisis go to waste. In many ways, when things are the most difficult, and surgeons are really quite good at this, when things are the most difficult and it's the most difficult to see a good solution, we come up with our own solution. We innovate. We create a solution that will help move the ball forward. And so I think the important thing for us to remember is that there is not going to be a single correct answer to a complex problem in a time of crisis. And there may not be a playbook that you can go to learn what you need to do. So continuing the innovative spirit that is part and parcel of what we are inherently as surgeons will allow us to have the best creative solutions to a problem, rather than going back to our standard old toolkit over and over and doing things that perhaps don't respond as they might to the crisis. Another important element is this notion of really being responsive. The challenge is that there's not always, I'm sorry, my phone is ringing, being responsive, because the information that's flowing back to us may help us create the right solution. And if you don't respond or continue to be mindful of the information that's coming back to you, then you may have a situation where you're not, again, putting together the right answer because you're not responsive to incoming data as well. The final point I'd make is actually a phrase that was used by my chairman during residency, and it's been emblazoned in my brain, and that is Dr. LaFall, who always said, you need to exhibit equanimity under duress. So in times of crisis, our teams are looking at us and expecting us to demonstrate equanimity under duress. That cannot be overstated. It's critical as leaders that we engender that confidence amongst our team. And if we can continue to remember the words of Dr. LaFall, we will never go wrong. So again, thank you to the organizers, thank you to my fellow panelists, and I look forward to the discussion and the Q&A.
Thank you very much, Dr. Turner. This is very useful advice, and we're going to move on to the second part of our panel, where we'll have speakers from all around the world. And I'm going to ask Girma to see with the introductions.
Yes, thank you for the really great words of recommendations, suggestions in this time of crisis, both by Dr. Turner as well as Dr. Hoyt. The speakers from the COSEXA region, which is the College of Surgeons of East, Central, and Southern Africa. I have two panelists, Dr. Godfrey Mugati and Dr. Eric Borgstein. Professor Mugati is a professor and chair of the Department of Surgery at the University of Zimbabwe. He is a clinical adjunct professor also here in the United States at Stanford University. He is the current president of COSEXA. He will be followed by Dr. Eric, Professor Eric Borgstein, who is a professor of surgery at the University of Malawi College of Medicine. He's a consultant pediatric surgeon at the Queen Elizabeth Central Hospital. He is the Secretary General of COSEXA. So I will just leave the panel to Dr. Mugati to say a few words about how he sees from his lens and how it has been in that part of the world, which covers almost 600 million population, if you will, in terms of the college coverage. So Professor Mugati, the mic is yours. You are on mute, just in case you don't realize.
Thank you, Dr. Tefera, and greetings to fellow panelists. I'm going to comment briefly on how this pandemic has unfolded in sub-Saharan Africa and highlight some of the challenges that we have had to cope with in the region and in the college, because we are a college that trains surgeons for a large part of sub-Saharan Africa. So the pandemic was first picked up in Africa, in Egypt, on the 14th of February, which means it has come to our region about 6 weeks after it first appeared in Asia. But the pandemic has been spreading rather slowly in Africa. And now we have had the pandemic for nearly 6 months. And the numbers in Africa are still nowhere near what we've seen in America and in Europe. A number of African countries introduced recommended measures, which include lockdowns very early on. In my own country, in Zimbabwe, we introduced the lockdown when we had only 8 cases and 1 death. Currently, we've started getting community spread, and the figure has risen to 500 infected cases and 6 deaths. It is possible that we may not be carrying out enough tests in Africa. But when one looks at the burden of disease as it comes into the hospitals, it still appears that we have not reached the levels of the severity of this pandemic that we've seen in America, Europe, and some parts of Asia. Like, for example, in my own country, we've not yet started admitting severely affected patients into the intensive care units. And I think this mirrors most of what is happening currently in sub-Saharan Africa. The only country that now seems to have a really heavy burden is South Africa, which currently has registered as much as 145,000 cases. And I think somewhere nearly 3,000 deaths. And my own country is a neighbor to South Africa. And most of the cases that we have diagnosed are imported, and these have come mostly from South Africa, Europe, and China. We think that the reason why the spread of this infection has been rather slow in Africa is because the amount of air travel between Africa and the rest of the world is not at the same level as it is in Europe and in the Americas. We have faced a number of challenges. First of all, I'd just like to highlight the challenges related to our college, because it's a college that trains surgeons over a very big region of Africa. We train in about 18 countries. And since there have been travel bans, in all these countries, we are no longer able to hold our meetings at designated, cities within the region. So in the last 6 months, we've been holding virtual meetings, mostly on the Zoom platform. But we found that it is actually quite possible to address the business of the college in that platform. And we've had to modify our approaches to how we deliver, instruction. Most of this is being done online. And we also have been forced to modify how later on in the year we are going to administer our examinations. Because it's not going to be possible to meet all the candidates. We normally would examine them during an annual general meeting in one of the countries, which is associated with the scientific conference. But this year, we've decided that the written papers will proceed as usual, but the clinical examinations will be held in country with live streaming from examiners from outside. So from the perspective of the college, the business is going on, and we are quite satisfied with the level at which we are able to run the college on the virtual platform. Now, the challenges that we have encountered in the clinical area have been largely to do with preventing of the spread of the infection within the community, but the governments have tried very much through lockdowns and encouraging social distancing, sanitizers to try and limit spread of these infections. But the biggest challenge that we have is making sure that we protect the health workers from infection, because as you know, personal protective equipment is always a challenge because of the expenses involved. But what has happened is that with this pandemic, we have all been forced to innovate. And a lot of our companies now locally produce personal protective equipment, some of which we have not produced before. And even more than that, a number of our engineering companies and technical universities have engaged in trying to produce ventilators. And these are still, to be commissioned. So one of the spin-offs from this pandemic is that local production of personal protective equipment and some of the resources that we need in the health sector may actually continue to be produced within our countries. We've also had to modify how we practice surgery within the region. And at the beginning of the pandemic, we stopped the outpatient departments and prioritized the emergencies and the management of urgent cases. And we've been preparing our patients, our health workers, to cope with an escalation of this pandemic, making sure that surgeons and anesthetists are well appraised about all the necessary, precautions they have to take, in the surgical area. I think I might stop there for now.
Yeah, thank you. I just want to make sure that the panelists, as much as you can, please stay within the time so that we can really have a good question and answer sessions at the end, because I am sure we will revisit most of it. And Eric, is there any additional thoughts from your side when it comes to activities in the COSEXA from, in addition to what Dr. Mugati has mentioned?
Thank you. No, I'll keep it brief, but yeah, there's a few aspects, and speaking mainly for Malawi, I think it's worth remembering that, our health systems in this part of the world are under siege at the best of times. So there's no slack, there's no room for, dealing with pandemics, and so for us the biggest risk is that, of course, if we start cutting back on numbers, as we have to, because we have to protect our staff, that we're going to be neglecting our patients. And, you're all aware of the neglected surgical diseases in this part of the world anyway. So the risks are that, we're going to have far more people suffering because we're not providing care, because we're taking precautions against a pandemic which so far in Africa, in most of sub-Saharan Africa, does not seem to have had the same impact as in other parts of the world. And that's presumably mostly to do with the median age in this part of the world being about 19. So there's that side to it. And certainly the spread has gone very slowly. Every country thinks most of the cases are imported, but there's no doubt that community spread is now happening in all the countries, and that it'll take much longer to reach a peak than it has in other countries. And it's just a question of the virus finding the niche of vulnerable people, which are less evident than in other parts of the world. So we have to be prepared to live with this for much longer. I don't think there'll be a peak and then a rapid decline. This is going to increase slowly. And the reality is that, of course, unlike you, we're not really testing. We're testing some, but not in large scale. And so there's going to be an awful lot more people infected than we know, but fortunately most of them are not symptomatic. That's one side of it. The other side is that, of course, here we've been living with a pandemic for the last 30 years. And so the whole concept of PPE and protection is very well established. And it hasn't taken much to implement really quite robust systems within the healthcare scenario. But of course, this is not happening within the general population. Social distancing, we've had, the national elections, presidential elections in Malawi over the last few weeks, and none of the rallies, unlike in America where they're all being canceled, the rallies all took place, and so social distancing really hasn't been happening. Thanks. I could go on, but I'll leave it at that for the moment.
Thank you, Eric. So I will go to the western part of Africa and would like to invite Dr. Emmanuel Izomi, who is a consultant surgical oncologist at the University of Nigeria Teaching Hospital. Dr. Izomi, the floor is yours.
Thank you, Girma, for the introduction, and I thank all the panel members. In particular, I thank the American College of Surgeons for the opportunity to have this conversation. Bring you greetings from the surgeons and people of West Africa. Talking about the pandemic, the COVID-19 pandemic, there are three important facts as the pandemic has affected West Africa, and which has important event for us in the terms of crisis management for leadership. The first, which has been mentioned, is that this pandemic reached West Africa a little bit earlier than the rest of most of the world. The first reported case in West Africa is in Nigeria, February 25th, and then quickly went to Senegal, Burkina Faso, Ivory Coast, and then Ghana. That allowed us some early leverage because these systems, you're able to see what's happening in the rest of the world, how was the system were overloaded, and then you're able to plan. Even with the limited resources you have, this is a big head of start, which we enjoyed. And as already mentioned, the numbers and the death rate in Africa has not been as badly as projected. And so this is another dream startup for us in that cases remain low. We can discuss over several days what's the reason for this. Some of us might think it's because we are very smart, but some will believe that we are damn good, very lucky that this hasn't hit us the way it is. In terms of crisis management, this is what we are looking for. And we pray that you overestimate the problem instead of underestimating it. And so we've been fortunate that this crisis hasn't hit us the way it has hit most of the world. The third fact is the point that in most parts of the world, they start opening their society when the infection rate is going down. But in our own part of the world, that's already been observed, we actually open our society when the infection rate is going up, even though it's going up at a more slower pace. And so for us in crisis management, we need to consider those things and how we can make best use of them. Looking at what we've gained, what we've learned in terms of what works best as best of procedures and protocols. The first thing I would like to say is that we learn quickly that surgical triage works. Early triaging and limiting of procedures have worked for us, and we believe is part of the reason, in addition to other things, that has made it possible for the cases to remain low in an environment as we tackle the problem. Okay, so apart from that early triaging that has led, different countries had their different systems, and so we're able to manage the cases as they arise in the environment, and that has helped. Then the other thing is that restricted activities has also allowed it to the early phase of it, so that transmission didn't progress so fast. Then for us in the surgical college, the very thing we learned and we had to do early was constant and early communication of guidelines and recommendations by the professional bodies. And it's important that since we are a college that covers so many countries' sovereignties, we have to make sure that these recommendations and communications align with what the countries have set up, their own system of operation, so that you don't pull in a different direction. So whatever we say and whatever ideas come centrally, the individual members in the different countries has to tell it to what is existing in their own country in order to implement that. But I remember actively the president trying to rally the executive and all the members to make sure that we have some messages in the website and be able to communicate with our colleagues. And some subgroups within our own body are able to have a meeting, come out with guidelines, looking at what's happening, for example, in the ACS website and what they've developed, and try to adapt it locally so that it makes meaning to our own people. And that has worked very well. And people, because of the trust they have in the system, you see a lot of the members, the surgeons looking at what do you have, what information, what guidelines, and what changes are you introducing. The other thing we had to learn quickly, and which has worked so far for us, that IT is not the best of level, but during this short period, we had to up our IT level and then how to coordinate our activities. All our officers from different countries of the region, and so we had to find a way of meeting, coordinating activities, coordinating the secretariat, and still be able to communicate with our colleagues. And we believe this has worked very well for us. In terms of challenges, we had a number of them. The most obvious actually the limitation in the testing capacity. And so we had to adapt to what's happening in the environment. Most of the cases have to be, even though COVID is not primarily a surgical problem, but because of the way it affects surgery and some of our patients might have it, you have to triage and then find a way of making a diagnosis even where you don't have the testing. And as we are moving into opening the society and opening the activities, this challenge will become more. Even though things have improved in terms of testing capacity, we haven't reached a point of universal testing. And so we've got to deal with it. And then in terms of limitation, this limited testing capacity is compounded by limited use of personal protective equipment. Some of them are because they are not there. And so the different groups, hospitals have to improvise. Using local production of PPE has actually improved, as somebody has observed, they improved that area. But the other issue we noticed that even when some of them are available, the use hasn't been optimal. First, maybe gaps in training, which we believe a college like us should be able to address. And also issue of finding it very inconveniencing environment. If you imagine wearing a high fidelity PPE in an accident emergency unit where I have no air condition, the weather is hot and humid. And so a lot of the personnel are not using it. So it's not surprising that in an environment, the proportion of healthcare workers that are infected with COVID relative to the number in society is quite high compared to the rest of the world, okay? Then what other thing we noticed that limitation in activity as a college and being able to run exams, as Professor Mogoti has mentioned, have a meeting. So we've transited to online meetings and we had to do this as much as possible. April exam was postponed and we merged it to October exam. Even that October exam, we're not sure, but what's obvious to us that we have to live with COVID. And that is very important that we have to find a way of surviving and managing the situation. Looking at the future, what the global surgical community could have done better, we think that we could have prepared for emergencies and crisis situations like this in a better way. We believe most of the colleges have bodies, arms of the college that deal with emergencies and extension into rural areas and outreach places. We believe that these things should be strengthened more so that when we have limited crisis, we'll be able to lend hand and help across the bridge and be able to help our colleagues from different parts of the world. Even in this crisis, we believe that down the line, you might find it useful that some of the equipment already produced in Western world, you might see that you don't need them there. You might need to find a means, and communication like this with different colleges will be important. They'll be able to find a means of helping each other. I will leave it like this and believe that when the conversation comes, we'll be able to comment more. Thank you very much.
Well, thank you so much. And the next speakers will be introduced by Dr. Tsoulfas.
Thank you, Girma. We're moving across the world to Europe, and our next speaker is Dr. Ronan O'Connell, who's the president of the Royal College of Surgeons in Ireland, and as well as president-elect of the European Surgical Association and emeritus professor of surgery at the University College of Dublin, Ireland. Dr. O'Connell.
Thank you, Dr. Tsoulfas, and hello to President Rush. Greetings from RCSI. And to colleagues. It's a great privilege to be on the same podium with colleagues from COSEXA because the Irish College and Irish Aid have been involved very much with your educational and exam programs. I'm going to very briefly tell you about what we faced in Ireland, what the college, how the college responded, and where we are now and the challenges we face. Briefly, we had our first case in Ireland at the end of February, and very rapidly our public health personnel advised the government that we were facing a real challenge. A public health emergency team was established, and we closed down schools, universities, shops, travel. We got into a very, very stringent close down very quickly. Fortunately, that has prevented the tsunami of cases that we could have faced. We certainly had a high tide, but at no time were our intensive care facilities overwhelmed or our emergency departments overwhelmed. We have had about 25,000 cases in a population of 5 million. We have had 1,700 deaths. The median age is 84. Which reflects the prevalence of the problem in care homes. During this time, most non-urgent surgery has been postponed, but we now have data on about 4,000 cases that were performed over the last 2 months. And it's interesting that those who had a COVID positive diagnosis at the time of urgent surgery had a 10% mortality. Which is certainly very high, but it is substantially less than is otherwise reported. What is interesting is that we created COVID-free pathways partially by nationalizing the private hospitals for about 3 months, which allowed us pathways that were removed from the emergency department and COVID positive patients. And within that pathway, we have actually had a 0.1% mortality, which is again outstanding. The chances of acquiring COVID when you came into hospital as a surgical patient were 1.3%, which is a great tribute to the nursing and other staff within the hospital. PPE was a real issue at the outset, and we argued very strenuously with the health authorities, knowing the resource restrictions that there were, that we would get PPE, and we've managed to internationally access those, and PPE are not issues right now. We developed guidance for aerosol producing procedures, and we liaised very closely with other international guidelines. And as a college, we produced a portfolio on our website that was constantly updated. There were webinars on a weekly basis every Wednesday night. And as president, I was doing a weekly newsletter, and more frequently if necessary. So as Dr. Hoyt mentioned, communication is of the essence. So right now we've got down to single figures in cases per day. The public health authorities, the chief medical officer, has been giving a daily update on national news at 6 p.m. And the politicians have not interfered with this. They have been guided by public health advice. The problem now, of course, is that when you close down an economy for 3 months, there's great pressure to open it. And like Greece, Ireland is very dependent on tourism, but we've kept a lid on it for the minute. The challenge now is it's all very well to turn off the light, but turning it on again and you find you're in a different room. And we've got the challenges of an endemic problem that's going to be there in the background. It's not going to go away. The second thing is we have to ensure that within our public health system that there are COVID-free pathways, and this causes space and capacity issues. So we're going, I believe, to look to, in the medium term, acquire capacity in the private sector in order to help us. As a college, that causes difficulties with training, because what we don't want is the low and medium complexity cases to be transferred out of the teaching environment into the private sector. And so we're working very hard with the public health authorities to try and ensure that the trainees follow the patients. So I think that just summarizes where we are. We're at the point of reestablishing elective care. We have managed, I think, reasonably successfully to cope with the acute problem, and I look forward to the discussion.
Thank you very much, Dr. Kyle. And I would like to move on to our next speaker from South America, Professor Alberto Ferreras, who is Professor of Surgery and Chair at the University of Buenos Aires, as well as being the ACS Governor of the Argentina chapter. Alberto, welcome.
Thank you, George. Thank you all for the kind invitation. The COVID-19 pandemic in Argentina started by late February. Most of the initial cases were imported from Argentinian tourists returning back from Europe. Another important point to stress is the fact that the economic indicators were really very low and disappointing in our country, which is subjected to a chronic economic crisis. From the point of view of leadership, this COVID-19 implied that we have been confronted to a very unique crisis and a real challenge for effective leadership. And I would like to raise and highlight a couple of reasons or a couple of points. One is uncertainty regarding the knowledge of the disease. Second, due to this fact, the lack of expertise and evidence regarding the pandemic. Just to remember, in March, there was huge discussion about the use of masks versus the not use of masks, the use of social distances, the use of chloroquine, hydroxychloroquine, or even famotidine. So this was an issue regarding misinformation and in relationship to the fact of communication that complicated a little bit all the management of the crisis. To add to the general panorama, the national government decided just to have crisis committee, which is integrated just by specialists in infectious disease. And this makes things a little bit worse since communications was not really the best. By today, Argentina, the figures that are announced by the government is that we have 75,000 people affected by COVID, and the mortality rises to 1,500 patients. In the meanwhile, the quarantine, it has been the longest, I believe, in the world. We go by 120 days, and it has been extended in a very stringent way until July the 20th. If we compare the data from March 2019 to March 2020, the number of consultations in the emergency room dropped by 75%. The general surgery procedures dropped by 75%, and the gastrointestinal endoscopies dropped by 82%. That means really a lot, and we have not been able to restart our schedule in the OR. This brings also another issue regarding the training and what we need to do with our trainees, including residents and fellows. The first decision from the Argentine Surgical Association, together with the ACS Argentina chapter, was to request an extension of the training program, which usually ends by June, and they have been postponed until October, and we are looking forward to extend them until December. So the new course would just start in January next year. Another challenge for effective leadership was that decision-making has been performed without exact data. Another issue which characterized the management of the crisis in Argentina has been the lack of resources. And that includes not only the lack of ventilators, as ICU beds, personnel. We must remember that in Argentina, ICUs are not managed by surgeons, but by intensive, quite different, they are clinicians. And also a word of caution regarding the testing capacity in our countries. Just to remember, the poor quality of the kits announced that there were less than 2 or 3% of asymptomatic patients, but then when they changed the kits, the number of the percentage of asymptomatic patients rose to 20%. I'm more than happy. I don't want to take more time than they assign. I'm more than happy to take further questions in the discussion section, but I try to bring a panorama of the country. If there are no other representatives from Latin America, I can give you some quick info regarding other countries. George, I'm at your entire disposal.
I think maybe we move ahead for the interest of time. Perfect. And keep that for the discussion. And I want to thank all the panelists to this point for really respecting the time. I think it'll give us more time for the questions, and I see that a lot of good ones are coming in already. Completing this trip around the world, Dr. Chintamani from India, who is professor and consultant of surgery at Vardhman Mahavir Medical College and Safdarjung Hospital in New Delhi, as well as president and governor of our ACS India chapter. Dr. Chintamani, please.
Thank you very much, George. And I would like to, first of all, thank the American College of Surgeons for giving this opportunity to share my information and ignorance on this pandemic that is really bothering the whole world. And definitely we're looking at a new normal in the future. We got our first case on 30th of January, and we lost the first case due to COVID in the first week of March. And the good news is that we could impose the clampdown very quickly, and that really did help. Having said that, there were many challenges to begin with, like it will be in any country like India, which is a land of paradoxes. At one end of the spectrum, you have hospitals that can now do the best in the world while we are struggling to provide basic healthcare in certain backwaters. So it was a huge challenge, and I think we reacted quite well and quite quickly. And this early clampdown, what it did essentially was that it gave us time to prepare for this. Now, the initial trouble was to have the PPEs in adequate numbers and to have the management of all the emergencies and the routine elective cases that was already alluded to by other speakers too. It's a challenge anyway, and especially in the field that I'm involved in, surgical oncology, the cancer patient, one has to choose whether one has to choose a triage in a manner that can be really, really very difficult to handle. The government did pretty well initially to convert a lot of resources that were existing, including the hotels, the train compartments into isolation wards, and dedicated them completely to COVID. And then we did adopt the private hospitals under a scheme where the government took over all of them as COVID centers. It did pretty well in the beginning, and what it did was it flattened the curve initially, but the tail seems to be looking like a long one and still wagging, and we are struggling to beat that end because that's a challenge. Now, the initial difficulty that we encountered was with the testing and also with the equipment, as I mentioned. This was gradually handled by developing our own PPEs, and now we are totally self-dependent. Like they say, adversity is the mother of invention. So many new things happened, which were good and bad at the same time. The attention from the essentially surgery-dominated centers like mine, which is tertiary care center, the largest one in the north of India, we had to channelize our resources towards COVID care. And what did we do? We had to part away with some beds for the COVID, which are dedicated to COVID. We did initially with the part-time suction or negative suction operation theaters, which were very difficult to start in the beginning, but took a little while, but we had to do that. And this was certainly at the cost of many elective cancer cases included. And that was very difficult to make a decision on. So there was a challenge at the same time as we were acting. The other thing that happened were that government imposed the Epidemics Act, where the clampdown was like you could not travel in between the states. Naturally, there was no international travel, and most of those routine activities which were happening were stopped. And then finally, they got very serious about it, and it was considered a punishable offense. Having said that, social distancing, which doesn't come naturally to people in this part of the world, and being such a populous country, it was difficult. Now, over the months that we've been facing it, the initial clampdown did help us, and we could actually manage it very well in certain states. I'm sure some of you would be aware, but I would share with you that in India, health is a state subject, and it's a democracy where with the volume is our strength and weakness at the same time. We need to take everybody along, and not everybody comes along. But fortunately, the politicians and the bureaucrats didn't really block it because it involved them to it. And actually, it was understood that it's kind of a war-like situation. People got together, and in between the states, the travel was stopped, and we are now finally on the 1st of July. We have 585,000 cases, with active cases being nearly 22,000, and we've lost nearly 17,000 people. But it's a huge country. We have tested more than 90 lakh people. It is still going on, and the things that we did differently, if I may share, it was touched by the previous speaker, especially the hydroxychloroquine. The nodal center was in Indian Council of Medical Research, and we had lots of publications happening in this period, and we have used it. And we used it in the prophylactic as well as therapeutic doses for these patients. In a surgical scenario, we had to triage our patients into those that needed it urgently. Those surgeries were done. All emergencies were done. Some cancers were allowed to be done. And gradually, the lockdown is opened gradually, and we have divided the country into 3 zones, red, orange, and green zones, which has really helped, because there are zones where you need to, even if one case is reported in the last 24 hours, it is reported. And now we're working on using the 3 T's, as they say. The one was testing, then tracing, and treating. So what was important was that we've devised that mobile app, which actually lets us know as to somebody who's come in contact with the COVID. I mean, I can go on that. That's been a real boon for a country like ours. Although there are challenges, but we've been able to flatten the curve, and hopefully we'll work at it to not let it be a very long tail. But as they all say, we are living in a COVID era, and probably we'll have to learn to live in the midst of disease. And maybe this has taught us a few lessons. So just at the end of it, what exactly have we got out of it? We could conduct, under the aegis of American College of Surgeons, 3 annual international medical student congresses, postgraduate conferences, and a PG masterclass, which actually was attended by 1,200, nearly 1,200 people. And that was a huge success. So all our MDTs, all our tumor boards, all our CPCs are now online. The classes are online, and we are having our exams happening right now. They're all online, and nothing got postponed beyond 3 months. So possibly we learned a few things out of it. The challenges are huge for a country like ours, which is trying to take everybody along. We've been able to do reasonably well. The lesson to be learned out of this entire pandemic pandemonium, for us at least, for our country, which I can share with you, is that we need to channelize basically our healthcare workers. And the biggest challenge that I faced as a leader of the team was, because ours is a COVID hospital, was to motivate the healthcare workers into working. PPEs are to be in PPEs for a long time is a challenge. There are technical challenges to be working in these negative suction OTs, but we have to learn to live with it. So I can go on, but I guess that should be it. And I'll be very happy to take questions at the end of it. Once again, I would like to thank you all for patient listening. Thank you.
It's wonderful. Thank you so much. And, we have really learned today that there is definitely different levels of incidences of the disease across the world, and also different levels of responses. And I just want to quote the Prime Minister of Greece, who, recently was quoted as saying to the question, how is it that you have really a relatively small incidents and problem in Greece? He said, we have been listening to our experts. That's basically his one short answer. And so that said, I think, there's definitely a lot of other things we don't know, and we're learning as we go. There are a few questions, and we can maybe categorize them in different groupings. So there's 2 questions that I will synthesize, and then maybe George, in the meantime, can look into the other grouping of the questions. So the first one here is about training. And yes, we are worried about our patients and ourselves, but our trainees are really going to struggle. And so what are the experiences? And then the second question that goes next to it is really, how about when some kind of a lag or discrepancy happens between the incident command and what is really on the ground, the communication, the timing, the speed of development of the crisis. So I just would like Dr. Hoyt maybe to take that question about, incident command and timeliness of responses, and just not, just being on the ball, if you will, so that the recommendations may be behind basically what is happening on the ground. And so those discrepancies happen. And so your thoughts on that, and then maybe Dr. O'Connell, if you can just bring back a little bit about the education piece, because I know you mentioned some actions you are taking for the students.
Yeah, I'll be brief, but I think you've touched on a really important concept. And I've been involved in several disasters over my professional life as a trauma surgeon. And there's a phenomena. The first time I really experienced it was in July 22nd of 1984, when we were about to open the San Diego Trauma System. And the week before we were about to open it, the McDonald's shooting massacre occurred. And we had, over the period of about 4 hours, 24 gunshot wounds that came in. And what happens during that kind of a crisis, it happened in 9/11, it happened here, is that everybody sort of transforms and wants to become a part of helping the solution. So the way that affected your specific question with us is we convened a group that included staff within the college, but it included probably 10 to 15 volunteers, mostly leaders, so regents, officers, and they were all busy taking care of patients, but they all attended these conferences so that when an issue came up like, what should our triage rule be? We were able to say to people, will you take this on? And oftentimes, if you ask somebody to write a chapter or participate in a study, you know how that goes. It takes a while for people to really commit to it. This was accompanied by, you bet, and I'll get it to you tomorrow. So we've actually tried to preserve that momentum as we come out with communications in general. But our leaders, and this includes Dr. Sutton and Dr. Roosh, but also many of our senior surgical leaders on the Board of Regents or our senior staff literally would take a problem, go off, run the literature, come up with a solution. We didn't necessarily put it into publication quality, but we got a solution. We discussed it through a consensus process, and then we'd put it out. And we did that repeatedly during the ramp down. That led to our cancer guidelines. The cancer committee took that on and produced a very, very comprehensive set of guidelines in about 5 or 6 days. It occurred then when we started to ramp back up, and then we shifted it to trying to encourage patients to come back and participate in surgery. So we had a group that did that. So the answer to your question, Girma, is I think you take advantage of people's natural tendency to want to help, and then you put them to work, you ask them nicely, but it also, if you can do that as a leader with a certain expectation, people really step up.
Dr. O'Connor, you want to tackle the student and the teaching issue that came up?
Well, this is a real issue that should concern all of us because we've had, like other countries, and I heard Alberto refer to it, our numbers of scheduled care surgeries are down about 70%, which is very similar to what you said. Interestingly, last week's college webinar was exactly on this with training, and the trainees participated. And I was rather surprised that they weren't as negative as I thought they were going to be. And what they said was that actually, because the numbers of cases were down, the mentorship improved. And this brought us to the issue of training to competence and not training to duration or numbers of care. And it's an interesting concept. We have, as I alluded to, being very straight with the health authorities that when we're reopening, and we have 35,000 undelivered cases over the last 3 months, that these are going to have to be delivered. We're going to have to find new formats of delivering them, but the trainees must go with the cases to get the opportunity of progression. Lastly, with the other Royal Colleges, because you may know that within the UK and Ireland, we have a common training scheme. We have been careful to ensure that work-based assessment, if that's adequate, trainees can progress. And we have deferred the intercollegiate fellowship, the exit exam, the equivalent of the boards, until November. We're looking at delivering this in a online way and looking at trying to develop clinical scenarios that can be delivered without actual patient contact. So that's what we're at the minute. But I was not as disheartened as I thought I would have been when we actually asked the trainees.
So it looks like I'm sure all the panelists will have some opinions with regards to how our learners part of the issue has been addressed, and I think that by itself is going to probably require an additional session to learn from each other's experiences, and maybe that might be a topic to address and share experiences a little bit more in detail. So, so I think just for the sake of time, and time flies, by the way. So we are almost 15 minutes out from closing the sessions. I know there are a few other questions that may be addressed, and I wanted George to ask the questions.
And several participants asked us about the overflow of information, of which medication to use or how things are moving ahead, and often contradictory. And I would like to ask what your thoughts are on how we can put together the information or be able to discern which are better or not. Maybe Dr. Turner.
Thank you. It's a great question. There are certainly, as you said, conflicting data that are coming in, and our physician surgeon colleagues are trying to discern what's right. The way that we addressed it at the ACS was to bring together really an editorial panel of experts across all surgical specialties who could really pore over the literature and review it. Read the peer-reviewed literature, make an assessment about whether that was a paper that really did make sense or one that was rather rushed through the process, being mindful of what it was that was on the minds of the members. So if there was information that came out, even if it wasn't perhaps a peer-reviewed paper, if it came down from a government source or from the CDC or from another trusted resource, trying to review that, vet it, and then turn it around as quickly as possible. There was an attempt on our part to put a little bit of framing around those papers and around those links, so that there would be a couple of sentences saying this is a review of this and such, and this is what our assessment is of this manuscript, and then sharing it. So again, in that way, we try to vet the information, turn it around as quickly as possible, and do the review on behalf of our members who are, again, trying to care for patients and trying to make those decisions. So it really was a matter of bringing as many individuals as possible together who were reading the literature in all of the different specialties. And then whether it was returning to surgery, how do you reopen, what are best practices in terms of deciding how to shut down, and putting that together and sharing it broadly.
Thank you. Another question that came up is about regional differences between one country versus the other. And several participants were asking about Latin America. And maybe Alberto, if you'd like to take this one, on difference, especially between, let's say, Brazil on one hand versus other countries in the region. What do you think happened differently? I think you need to unmute.
The situation in other countries in Latin America, it's quite different. I would say that the worst situation is happening in Chile and in Brazil. In Brazil, I will not speak about the Brazilian government, Mr. Bolsonaro, but there has been ups and downs regarding what to do and what not to do. They go since the appearance of the crisis. So since March, I think they are going by their second or third health minister, and that has been complicated. There are many physicians who have been, including surgeons, who have been suffering from COVID-19. And I think the situation is particularly very difficult in the big cities like Sao Paulo and Rio de Janeiro. A similar situation is going on in Chile. In a different situation, we can group other three countries. I'm speaking mostly of Southern South America, and in those countries we can include Uruguay, pretty small, 3 million inhabitants, Paraguay, and Bolivia. Although Bolivia is undergoing a new burst of the disease in one of the richest area, which is the closest to Paraguay. So I would say that through contact with my colleagues there in these countries, the situation is pretty similar in Argentina, and as mentioned, the lack of evidence, and also another issue which applies both to Chile and to Brazil is the lack of truthful and trustworthy communication from the government.
Thank you.
So there are a few more questions here. So the one is if Dr. Roush, if you want to comment a little bit about the communication, and I know we are in the process of together putting out a paper, if that can really give a little bit of an insight as to how this whole situation will handle, how to really navigate communications. And the second question I have is, for particularly countries, colleges that have a much broader reach, meaning, across borders, like in the West African College of Surgeons or the East African colleges, as well as also in India, because in India you have to go across multiple cultures. And so I would like to hear also from the three of you, Dr. Muguti and Izomi and also Chitimani, about how you dealt with this centralized manner across countries and cultures. But I just want to hear first from Dr. Roush if she has some additional thoughts about the communication piece and getting, at least a center, a repository for surgeons to understand the problem.
Well, yes, I think we've heard over and over again from the other members of the panel how critical the communication piece has been. And as Dr. Hoyt indicated, it's where we started the crisis management process, which was to try to develop a single, rapidly available source of information, readily readable, readily accessible to all physicians and surgeons. And I think that is really a pivotal part of how we've approached this crisis. And I think we've heard from Dr. O'Connell that it has been working very successfully in Ireland, and as well as from some of the other panelists. And I would just second what Dr. Turner talked about in terms of having a small editorial group to really scrutinize the many, many publications of varying quality that became available during the height of the pandemic, and trying to sift through the information and deliver to surgeons very quickly in a very readable way the truth, the scientific guidelines that they could use in their daily care.
And thank you. And any thoughts from how did you manage across borders, Emmanuel, or were you limited to the local politics?
Thank you, Girma. For us in West Africa managing, that's a challenge which we have to find a way around it. Our sub-region has different sovereignties. So when we have opinion, recommendations, we have to work, each nation has to domicile it and tailor it to their particular need. And some of our member countries, there are no other college for training of surgeons except ours. And in those instances, we've got to relate with the ministries of health. Unfortunately for us, within those ministries, a lot of them are manned by our fellows. And so it becomes easy for them to domesticate and be able to pull these recommendations into their system and then be able to implement it. For those colleges where we have sister colleges within the countries, fortunately, some of our member fellows are equally fellows of those sister colleges. And sometimes we had to call intercollegiate meeting to be able to arrive at a consensus, which we push through to the ministries and be able to implement it. So for us at the West African College, it's not easy to make a one-size-fits-all recommendation. Whatever you recommend will be a basic minimum principle that will cut across, and then within each country, they have to domesticate it as their particular situation demands. That's how we've been able to manage and be able to have influence in what happens in the different countries. Thank you.
Yeah, thank you. So I think, this probably becomes an impetus to maybe have for the future, this is an opportunity to see what kind of a common channel could be created. So briefly, Professor Muguti, do you have some additional thoughts? And then Professor Chitamani as well. First, let me go to Godfrey.
Thank you, Professor Tefera. So it is fortuitous that this COVID pandemic has come at this stage for our college, which is a relatively young college. It's just over 20 years. But it has come at a stage when our systems are fully established. And our council, is very well established. The people in council know each other. So it's very easy to do business. And the other thing is the majority of the countries in our college are Anglophone. So language is not a major problem, it's not a barrier. And we also have common origins in terms of our education systems are rooted. So there are two channels of training in our region. One is through the College of Surgeons of East Central and Southern Africa, which is the collegiate system where the programs run for 5 years. And the other throughout the region, which preceded the college, were university-based programs, which we call Master of Medicine in different surgical specialties. So there's really uniformity in terms of how we educate doctors, how we train surgeons. And so as a college, it has not been very difficult for the different countries which are constituent members to actually relate to each other. And it also makes it very easy for decision making because the roots of our education systems are not very different, most of which I think take on from the British model. So, so I must say that the reason why I was saying it's fortuitous this pandemic has struck at this stage is that our systems are solid, they are well structured, and it's just a question of changing the platform in which we interact. Getting more of the business done online as opposed to physical contact, which in the past has obviously involved a lot of traveling. So we might have learned something, with this pandemic, that we can conduct a lot of business without the expenses of traveling. Although, of course, going forward, when the COVID, eases off, we will continue to interact because there's always a social activity aspect, to all these things. But for now, I think as a college, we think our systems are in place despite the pandemic, and we are quite convinced that we'll be able to deliver our mandate to our students and to our different nations. Thank you.
Yeah, thank you. And I know we are about 5 minutes beyond our allocated time, but I would like to give Dr. Chitamani to say, to use maybe 2 minutes to, say a few words about this issue across different cultures in a big country.
Thank you, Professor Tefera. It actually truly has been a joy listening to everybody. I'll just quickly run through it. There is the center of command is actually the Indian Council of Medical Research, which usually is able to deal with all states. And you're right, culturally, as you travel 100 miles, India changes, and it looks like a continent of various countries put together. But fortunately, at this point of time, politically, administratively, they all got together with few differences here and there. But like I said, health being a state subject, it can be a challenge, and it was. Well, we, under the aegis of American College of Surgeons India chapter, we conducted COVID webinars, 3 of these. We have included all the states and everybody from all corners, and we could get experts from all over the world. And to us, for us, it was very useful to get those guidelines from the college which we could spread across, and we could share with everybody as to what guidelines and how can you find Indian solutions to the Indian problems based on these guidelines. And some guidelines were created that were essentially of the ICMR, and then various associations of surgeons, including the regional and the local associations, and the Asian Society of Mastology, who I happen to be its president. So that entire group was included in the other two conferences that we did. For the postgraduates, for the learning part that you were mentioning, to conduct webinars for 3 days, and for the undergraduates internationally, all under the aegis of American College of Surgeons, Indian chapter. We could find that it is possible to connect them all, and most of them were sharing the same views and the guidelines. I would also like to touch on that, because finally we are flooded with information, and somebody's got to name them and channelize them into really the ones that can be implemented. We are getting there gradually. There's a bombardment of information as of now, but gradually it's falling into place. And that's how across the states, we could get all of them together. And there are a huge amount of people who are now getting involved as actually the editorial group. For the Indian chapter, we've got one, which filters these guidelines and puts them across to most of the surgeons practicing across the country, so that the practices are applicable. Number two, they're reproducible and they're evidence-based. Thank you.
Well, thank you so much. And, before closing, I just want to, give George an opportunity to say if there's any final comment he may want to do.
I just want to say that thank you to all the panelists, first of all, and thank you to the people attending. I think this was a great opportunity to hear about the challenges, about the issues, and where we stand right now all around the world. I think this is also a first step. This is the beginning of similar webinars that can happen even in a regional setting, so that we can all benefit from this knowledge, especially since there are newer challenges coming ahead of us. Girma?
Yeah, thank you. So in closing, I just want to say thank you to all the panelists, everybody, for spending the time and sharing your experiences. And I echo what George said, and I think we will have some additional ongoing connectivity with webinars. And even in our discussion today, it looks like we have brought in some things that we can learn from one another, be it education, be it communication, and others. So I think we'll make that happen. I just want to say thank you to a couple of people who are really, really instrumental in organizing this and putting this together. Particularly, I have Natalie Bell, who is the manager for Operation Giving Back. She has been working on this day and night. So thank you, Natalie. And our IT Division Chief, Brian Harper, who has really been helpful in getting the platform for us and moving in that direction, as well as Kathleen McCain, who is not on the panelists here, but she has been amazing actually in trying to get all the information and the news out to all the international fellows. And with that, I thank everybody for being here today, and I hope this was very helpful, as it definitely is and has been very helpful for us. So see you, and thank you so much.
Thanks.
Thank you.
Thank you.
Thanks.